right, welcome everyone. This week we'll talk about aortic stenosis. We'll try and keep it as interactive as possible. See how we go. So we'll look at the principles of echo assessment in aortic stenosis, talk through a little bit about mechanism, of course, severity, and some pearls and pitfalls. And we'll have some cases. We'll sort of ask some questions as we go through and then have some cases at the end, hopefully 2 to 3 cases. So like everything, you still be sort of common theme to you now with valve assessment. We like to be fairly structured and methodical with that. 2D assessment, colour assessment, and pulse and continuous wave Doppler assessment. And that, of course, gives us an echo assessment of severity. And as we know, we need to really sort of see the whole heart with that and what the effects of remodeling, are on the LV, left atrium, pulmonary circulation, RV, as well as integrate that obviously with the patient's clinical history to come up with what their severity is, whether they're asymptomatic or symptomatic. And obviously it's a little bit different in the critical care setting. And we'll talk through some of the sort of pitfalls with that. So the etiology of aortic stenosis, which will be, I think, familiar, common causes that you're going to see a lot of the time is going to be calcific aortic stenosis, more in elderly patients sort of over the age of 65, usually have a background of hypertension, maybe have some renal disease and things like that. Rheumatic, obviously we see this less commonly, but when you do see it, it's usually fairly obvious. They have that sort of doming of their leaflets and also that commissural fusion, just like in rheumatic mitral valve disease. Bicuspid valves, as we talked about last week, in about 1 to 2% of the population tends to be younger patients. So those are less than 65, and you need to always assess for whether the valve could be bicuspid or not. And then uncommon causes, right? So congenital, radiation, subvalvular and supravalvular pathologies. So calcific, in terms of a 2D appearance, does anyone want to have a go at describing this valve? You had to describe how it looked. That's all right. It's probably tri-leaflet. It's heavily calcified and thickened, particularly of what looks like the right and the left cusps, and there is severely restricted opening. For the valve at the bottom, we talked about this last week, so I'm not going to go too much into the normal anatomy, but that's a normal valve, isn't it? So this is top one's with TTE, this one's with toe, and as I said, that normal valve area is about 3 to 4 centimeters squared, nice thin leaflets, tricuspid, and yes, you can see the clear difference there between those normal and a calcific valve. As I said, rheumatic, it tends to be commissural fusion with thickening of the leaflet tips, and there's some clues to sort of detecting that. Any volunteers to talk through this one? We have a parasternal long axis with quite significant mitral annular calcification of all the posterior mitral annulus as well as the aortic mitral curtain. But the leaflets themselves in the mitral leaflets seem to be opening reasonably well. The LV looks normal size, but possibly some increased LV wall thickness, possibly smallish cavity size, isn't it? And then this aortic valve looks moderate to severely thickened with moderate to severe, restricted opening. And the zoomed in view of that just confirms all of that as well. And then what we would do after looking, in 2D, we would add colour, and generally what you see is turbulent flow coming through the valve. Often you get some flow turbulence just proximal to the valve as well. And in really severe cases, often you don't see any colour flow past, much past the valve, and that just is signifying quite critical stenosis, often when the LV is impaired as well. So you can get a few clues from looking at colour. As always, make sure you're, understand the things that affect colour appearance are going to be the frequency of your transducer, the gain settings. So making sure you haven't got too much speckling all around, because then your gain's too high. And then, of course, the scale as well. So generally between 50 and 70 is where you want your colour scale to be, to make sure you're not, getting aliasing when there isn't any turbulent flow. All right, we went over this a little bit last week. This image here on the left, my laser, does anyone want to comment on the 2D appearance of this valve? You're all very quiet today.
I can. It looks like a bicuspid valve with fusion of the left and the right coronary leaflets. I think it's a transthoracic image. There's reasonable excursion of the non-coronary cusp, but those left and right are fused and maybe a bit calcified at the fusion. Maybe overall has reduced opening compared to a normal valve.
Love it. It's brilliant. Perfect. Yeah. And this is the RAFA here. Hey, Michael. She said, and guys, we talked about this last week, but that elliptical opening. So if we pause it in mid-systole, and just to show everyone that as well. So if we see that rather than that triangular opening, we're seeing that elliptical lens shape opening. That's again, should cause you to pay more attention to that valve. And once you've seen a few and things, you'll get used to it. But yeah, can do these little tips just to sort of train your eye to what you're looking at. So Michael, if you saw this valve, what else would you want to immediately, well, not immediately, but like as part of your study, what would you be looking for?
I'd try to get some good images of the ascending aorta to rule out things like an aneurysm for some sort of associated aortopathy.
Yeah, very nice. For sure. Yeah, so it's not uncommon for these guys to have aortopathies. What else? I guess it's included in that. You've mentioned dilatation.
Coarctation.
Coarctation, yeah, I think. Again, I didn't look this up after last week. Somewhere between 1% and 5% of them, something like that, maybe 1% to 2% will have a coarctation. As opposed to if you've got a coarctation, then about 50% will have a bicuspid valve. How about this one? Anyone want to have a crack at this one? What's this 2D appearance of that? Would you want to describe it?
It appears quadricuspid.
Very nice. Is that good on you, Rob? Yeah. Yeah, very nice. And there's a central coaptation defect, isn't it? But if this valve hasn't got stenosis, it's wide open, isn't it? But they can, develop things like that. So they're at risk of getting degeneration and things like that as well. This patient will probably almost certainly have some aortic regurgitation. All right, so this one's a little bit trickier. But I mentioned at the beginning some of those other rare pathologies as well. So if anyone wants to have a crack at this one, it's not easy and it's not the best view. You would need more confirmatory views, I think, as well.
I can have a go. It looks like it's a slightly off-axis apical 5-chamber view on a transthoracic echo. And maybe there's maybe a centimetre or so into the LVOT from the aortic valve that looks like there's a bright structure, echogenic structure, but projects into the LVOT. I'd like to confirm it in other views and to have things like colour Doppler and continuous wave Doppler, but it could be a structure that's causing, especially in the talk about aortic stenosis, a structure that could be causing like a subvalvular, subvalvular membrane causing stenosis, subvalvular stenosis, I should say.
I'm going to go home now. You guys don't need me. That's awesome. Yeah, nice one, Michael. So then this patient had a TOE which showed it beautifully. And the most common type of subaortic membrane causing subvalvular stenosis is like the linear type, where you just get that really sort of discrete thin membrane prior. So yeah, sometimes this can catch you out. We've had a few cases, I think, of subaortic membrane. That's not the subaortic membrane, that is way out. That's has moved, but and then other things like so really important, just like we talked about with aortic regurg, it's not just about the leaflets, the cusps, and it's about the aortic root as well. So, and your LVOT, so looking below that for subvalvular things, and very rarely, these supravalvular stenoses as well. It tends to be with other congenital things. You can see them here where you would get supravalvular stenosis. They like to ask these kind of questions again in the ASE exam, and knowing what congenital conditions are most associated with this. Assessment of the LV and the whole heart really is important, isn't it, whenever you've got the valvulopathy. Of course, in AS, they've got this progressive obstruction, chronic pressure overload, and they get these compensatory changes, thick concentric remodeling of the left ventricle, as opposed to AR with predominant volume overload, where they get eccentric remodeling they get concentric remodeling in AS. And often as that progresses, the natural history of things is that they obviously develop hypertrophy, but they also get fibrosis as well of the left ventricle, and that's important to detect early, and we'll talk through some of that here. So of course they have this high afterload state, and ejection fraction is very load dependent. So you might have this patient that has this really high LV afterload, and so because of that, their EF is down, but they have a normal myocardium. So their myocardial function is actually okay, but because their afterload is really high, their EF is reduced because of that. And that's known as afterload mismatch. And these are the groups where if you fix their valve, fix the obstruction, their EF will improve. But of course, you're going to have subsets that develop this fibrosis, and they develop LV failure. And it's not just because of afterload mismatch that they develop LV dysfunction, but it's because they have intrinsic myocardial injury because of, the natural history of things as well. This isn't like this, GLS is, so global longitudinal strain of your LV does seem to have prognostic value in aortic stenosis, but especially in those perhaps where, this study showed it here, where they have a normal EF, these patients, and they had cardiac MRIs and looking at their strain values as well. And basically those that had more fibrosis had much worse global longitudinal strain, and then their outcomes, so their mortality. So this is those with GLS, global longitudinal strain that was greater than -21, was they had, they survived longer. Those between 21 and 15 had sort of intermediate risk, and then those with global longitudinal strain of less than -15. We tend to use -16 as our cutoff for being normal here. So those around that figure had a much worse long-term outcome. But in the guidelines, you'll notice that there isn't, any set rules for how this can help guide management in terms of timing of surgery and things like that. It's still very much a research domain, but it's interesting nonetheless. And we seem to be doing more strain in these patients as well. It's obviously a very cardiology domain, but knowing something about that's probably useful. And again, these kind of things is, you need to know a little bit about them for the American exam. You won't be expected to know this for the DDU level. Grading severity. So let's go through some of this then. This is really the table that you just need to have imprinted in your brain, especially this severe column here. So the things that we're going to be looking for: peak velocities more than 4 meters per second, mean gradients more than 40 millimeters of mercury, aortic valve area less than 1, indexed aortic valve area less than 0.6, but you would avoid using this in really obese patients. It's less accurate. And the velocity ratio, which we'll talk through, of less than 0.25. All of those things, a severe aortic stenosis. And then we have the mild values here, and then moderate in between. So 3 to 4, 20 to 40. Valve area is sort of less than 1.5 but greater than 1, and velocity ratio between 0.25 and 5. I think after a little bit of practice like these, they kind of do get a bit imprinted into your into your brain there, but they're always, easy to look up if you forget. All right, so how do we obtain the peak velocity? This has stopped working, sorry for that. I had this as a separate thing. Sorry, guys. All right, this should work now. So angle is everything in Doppler. So the way that we're going to obtain that peak velocity is by making sure our Doppler angle is aligned as much as it can be with the flow. And we're going to do this in the apical windows, but we're also going to do, apical 3 and 5, but we're also going to do in an aortic stenosis study, looking at right sternal edge as well as suprasternal, maybe supraclavicular as well. To be honest, I find that really hard and usually need a sonographer to help me with all of that. But also don't forget subcostal imaging as well. And I'm going to show you a case at the end where the highest gradient came from the subcostal region, which is quite rare. But yeah, worth remembering, especially in our patient group. So you would usually put the colour on to help guide where you're going to put your cursor, and then pop the continuous wave Doppler through that, line it up as best you can. And then, of course, you're going to get a spectral Doppler trace that'll look something like this. And it's quite...
Sorry, Emma.
Yeah.
I'm not sure you're sharing your screen anymore.
Oh, sorry.
That's okay.
Hang on. Share. Can you see that
That's
now?
good.
So sorry.
Yeah, perfect.
Let me
That's okay, thank you.
No, let me just go back on that. Okay, so yes, so you'll have your, whether it's your apical 5, which is what we're in now, pop color on that because you want to line up your jet with the flow, the isonation beam. Drop your continuous wave Doppler through that, lining up as best you can, and of course the modified Bernoulli equation 4v squared. You're going to get your Vmax, so 4.7. Square that times 4, that will give you your peak pressure, and then it also gives you your mean pressure here as well. So you'll often see in aortic stenosis, you'll often see this sort of spectral Doppler profile, where it can often be brighter initially up here, and this is actually your V1, like your LVOT flow, which is the predominant red cells are coming through at this sort of velocity prior, and then the rest of your red blood cells are coming here, and the peak velocity is the one that you are interested in. So obviously not having it overgained, ignoring the fuzz and all of that is important. We'll talk through some of that. I was going to say something else about dropping that through. Maybe it'll come to me in just a second. Oh, that's what I was going to say. So before I move on to that, what would you, so this is the simplified Bernoulli, right? 4v squared. But how about if your proximal velocity was, you had lots of turbulence leading up to the valve and your proximal velocity, say, was 1.7 or something. Does anyone know of any way that you can try and correct for that?
You could revert to the simplified Bernoulli equation and use because normally you assume that the proximal velocity is less than 1.5, but
nice.
if you could measure V1, then you could use the simplified rather than the modified, or maybe I've got those terms mixed up, but the other one where you include V1.
Yeah, very nice. So the sort of extended or the normal Bernoulli, actually, because we use the modified age at 4v squared is the modified one, because you can usually ignore that proximal velocity. So this is out of Benita Anderson's book, and she actually used it. So the ASC guidelines use this cutoff of 1.5, but Benita has 1.2, and asking various people, I think most of us actually use 1.2. So this is just showing that here. So we've got an aortic Vmax of 2.8, a mean gradient of 16.3, but our proximal LVOT velocity is 1.29, so over that 1.2 threshold. So we need to essentially subtract that. So normally we would just have this, right? So 4v squared, they've labeled aortic valve velocity is V2 and your LVOT velocity is V1. So normally we wouldn't have this part in it, right? That would just be gone because it's usually negligible. But because it's more than 1.2, we'll include that in. So 32 minus 6.6 is 26 millimeters of mercury for a peak pressure gradient rather than 32. So you're correct for that. Now, the guidelines are a little bit, they basically say that we probably shouldn't apply this for mean gradients. I don't know, but anyway, in Benita's book, she does do the same thing for correcting for the mean gradient, which would be 16 minus 4, which would give us a mean gradient of 12 as opposed to 16. And then just the other thing I was going to say about this trace is don't forget to look at the shape as well of the spectral Doppler trace, because as you get, does anyone know what would happen if you had progressive obstruction? Would it become more triangular or more parabolic as you got worsening obstruction?
It becomes more triangular, does it? The peak becomes later?
Parabolic.
Anyone else?
I think more parabolic, because as the obstruction increases,
yeah,
it becomes slowly reaches the peak.
Yeah, very nice, very nice. So exactly right. I couldn't say that better, Rishi. So it becomes more parabolic the more severe the aortic stenosis. And that's opposite to mitral regurgitation. And that's one of the things that you can do to differentiate the jet, which can sometimes be hard. Mitral regurg starts off parabolic when it's mild and then becomes triangular when it's more severe because of that V cutoff thing that's happening. So important to look at density, making sure you've got your gain settings right, making sure you're not tracing the fuzz down here. And yeah, look at getting an idea from the shape as well. There's another reason why you might want to look at the shape, and I'll show you that at the end when we talk about dynamic versus fixed obstruction. So this is, if you don't remember anything else, this is probably the most important slide to me. It's especially, I'll talk about some of the problems in critical care, but we need to be hunting for that maximal velocity. And it's really quite hard. If you only stick with apical views, whether 3 or 5, you're going to miss the highest velocity in about 20% of patients, which could have significant implication potentially. So when these patients come through our sort of outpatient setting, you'll often see that the sonographer are using a lot of these probes, which are the PDOF probes. The way that you can spot that they've used them is that you don't have the little thumbnail at the top, and often it'll look, the tracing will be something that you don't recognize, and they should be labeling it as well. So this is right sternal edge. We've got flow coming up, and we've got a peak velocity of about 4.21. This is suprasternal, so in the suprasternal notch, and you can see the footprint of the PDOF probe, which is just a continuous wave probe. It doesn't do anything else. So you've got constant back and forwards of your signal. So you can get really high velocities with it. And the small footprint means that you can, sort of maneuver it a little bit easier. You have to have the sound turned up because it's all about listening. You don't get any visual display of where you are, which makes it really tricky. And there's a lot of there's a learning curve with it, which I haven't quite mastered. And then this is the apical. You can still use the PDOF in your apical windows as well. The problem with this sometimes, this apical one, when you're using the PDOF, is that you can actually pick up the mitral regurg. And if you don't know what you're looking at in terms of, sort of not including the isovolumic periods, I've seen people get confused with and call the mitral regurg jet AS, which is obviously bad because it's often 5 meters per second, right? So you're saying that someone has pretty much like critical aortic stenosis. So yeah, there's a bit of training involved with interpreting the waveforms as well, making sure you're not getting cross-contamination with the mitral regurg. And as I said, that subcostal view can sometimes be handy to pick up the highest gradient as well. And I think this is quite a nice visual to show the direction of the blood flow coming through the stenosis. So in your apical window, it's obviously moving away. So we've got it below the baseline. And then as you go to your right sternal edge, suprasternal and supraclavicular, you can actually see why you get pretty good tracings there because it lines up beautifully sometimes. And as I said, yeah, in about a fifth of patient, if we only use apical, we'll miss that highest gradient, which is important. Peak velocity, again, that natural time course, it's prognostic. So that, I think is pretty self-evident, and it really makes a difference. Someone between 3 and 4 compared to over 5.5, their survival is much, much less. So it's highly prognostic, the aortic valve velocity. There's a fair amount of data on that. And it's not just the actual number, but it's the rate of change as well. So I think this is the Rosenheck study, I can't quite remember, but if their velocity increased by 0.3 meters per second or more within 1 year, then most of them underwent surgery, or if not, they died within 2 years. So the rate of change is important to keep an eye on as well, which is really important that you're doing the same thing every time when you're following these patients up. And this is what I was speaking about before. So having the sweep speed should be between 50 and 100. You don't want to have more than maximum 4 on a screen. You can see this has got 4 on it. If we went to 100, we'd have 2. So yeah, making sure you definitely don't have more than 4 spectral Doppler traces, because you're just going to lose your accuracy with tracing. Ignore the fuzz. So all of this stuff down here, you'd be ignoring that. And once you've found your highest velocity, then you want to be tracing out ideally 3 and averaging those 3 in sinus rhythm. And if you are in atrial fibrillation, then 5 to 10. I must admit, I haven't quite got the patience to do 10 tracing. So I generally find where the highest velocity is and then trace out 5 if they're in AF or 3 in sinus rhythm. There's this concept of pressure recovery. So as we all know, when you've got a flow coming, a fluid jet coming towards a narrowing, we get a turbulent flow acceleration. So we get an increase in kinetic energy, a drop in potential energy. So this pressure drop that happens here. And then as the flow goes through the narrowest point where we've got the lowest pressure, it then drops its kinetic energy again and then picks up pressure again. Okay, and this is known as pressure recovery. Okay, so this is what happens here. We get this pressure recovery. What that means clinically is that if we cath someone, the cath gradient, so this is our LV pressure time graph here. When we do cath, when the cardiologists do cath, they would measure the peak to peak gradient. All right, so they measure from the peak of the aortic waveform, peak of the aortic pressure, to the peak of the LV pressure. As opposed to with Doppler, when we're measuring with Doppler, we get the maximum instantaneous gradient. Okay, so rather than it being peak to peak, we get the maximal one. So what that means is with Doppler, we tend to get slightly higher gradients than with cath. Usually it doesn't matter too much in most patients, so you can ignore it. However, there are times when pressure recovery can be clinically significant, and this is in patients that have bileaflet aortic valves, mechanical bileaflet valves in particular, because they get more pressure recovery, and so we tend to overestimate their gradients with just Doppler alone. There's increasing literature coming out, and there's a really nice paper that was in JACE, I think in last month's JACE, actually talking about the discrepancies between cath and Doppler in patients post-TAVI. They looked at, it's a really nice paper, I can share it with you. They looked at native valves, surgical AVR and TAVIs, and looked at some of the problems with the simplified Bernoulli and pressure recovery and things like that, which is why there's discrepancy. And then sometimes you can have this problem in patients with really small aortas. I must admit, I've never needed to do anything like clinically for pressure recovery, but it is important to be aware of, and it does come up in exams sometimes as well. So just for you to be a bit aware of that. This is why to me, I'm really hesitant to grade someone's aortic stenosis when they're critically ill. I think sometimes it's like really obvious, right? But a lot of the time they're in this grey zone, and their flow state is so fluctuant when they're critically unwell. They're on pressors, their volume status and things is all over the place. And because these gradient velocities are so flow dependent, like it's really quite hard to know where you're at in terms of, their sort of footprint severity. So we just have to be a bit cautious with, overcalling or undercalling, I suppose, both ways. So, of course, if we have high flow states, high cardiac outputs, that's going to increase our velocity, increase our gradient. So we might be overestimating the severity. Similarly, if we have someone with a septic cardiomyopathy or something like that, then, they might have severe AS, but we end up calling them moderate if we don't know what we're doing with Dopplers and things. So they can be really quite complex, I think, to assess, especially when they're with us, poor windows, as well as these dynamic flow situations, makes it really challenging. So if they have a high flow status, like they've got a high cardiac output for whatever reason, or aortic regurg, so this patient, for example, then we would need to determine whether that high flow status is reversible or not. And most of our patients, I would say, have this reversible flow status. So what I usually say when I'm reporting these is reassess the severity of the aortic stenosis once they're over their critical illness or something. So this one here. But if it's not reversible, i.e. this patient with the, with the aortic regurg, then you just have to report it as it is. So they've got non-reversible high flow status, shunt aortic regurg, something like that, then you still call it severe AS. And that's because having moderate AR and moderate AS have pretty much the same prognosis as severe AS. And there's some things that you can do to correct for the flow state, and that's calculating their aortic valve area or their DSI, which I was going to ask you about. But the thing, as we talked about, that's really correlated to their prognosis is what their Vmax is anyway, what their peak velocity is anyway, because it's this peak velocity that's representing the hemodynamic load on the LV. Yeah, and I mean, if you haven't got a high flow state, so you've excluded the high flow state, then they've just got normal severe high gradient aortic stenosis. And we'll talk through some of the different sort of special circumstances with that. So the way that we can try and normalize for flow is working out the aortic valve area. And this uses conservation of mass theory, which you'll be used to, I think, from going over valve stuff before, but we'll just talk through the basic principles. So we know what comes in must go out. So A2 B2 equals A1 B1, and then we can rearrange that equation because what we're interested in is A2. So the effective orifice area here. So we can rearrange that equation. So this then becomes your LVOT cross-sectional area times the LVOT VTI over your aortic valve max velocity. And that will give us the aortic valve area. And we talked about Vmax being prognostic. Well, aortic valve area is also prognostic with those with, this is where the severity thing comes from, right? So if you've got an aortic valve area of less than 1, you can see the sort of Kaplan-Meier survival curves there, pretty dismal natural history. So people tend to ask about planimetry. It's rubbish. I would avoid doing it, especially with TTE. You get so much blooming artifact, and it doesn't correlate very well with calculating it from the hemodynamic Doppler data. And you're really, and as I just said there, it's that effective orifice area rather than the anatomic orifice area, which is where all the prognostic data comes from anyway. If you are going to do it, you probably should do it with toe. And there's been some work looking at 3D, but it's a way, it's sort of validation. So you can do it, but I wouldn't be hanging your hat on it essentially. And it's not part of the in the table for assessing severity. So this is what we are really using. So we've done peak velocity, we've done mean gradients, and then we look at the aortic valve area. And the things that we need are 3 things: LVOT, VTI, left ventricular outflow tract diameter, and then aortic valve VTI. It sounds easy, right? But there's so many things that can go wrong with each of these things. We've sort of covered the things that can go wrong with Vmax in terms of being overgained, tracing out the fuzz, not having your correct Doppler angle is probably the biggest thing, and not hunting for that highest gradient. So we've sort of covered that already. So I'm going to focus now a little bit on the VTI. So what can we do wrong with this? I think the main thing that we do is either underestimate or overestimate the VTI. So a couple of ways we can do this. So we all know that flow profile, so fluid dynamics, fluid coming in, narrowing here, get lots of flow turbulence. Now, if what we want to measure is the modal velocity, which is the average velocity of the red cells as they're coming towards the valve. That's what we want. We don't want the peak velocity. So you can see we want this sort of flat profile here. We don't want this peak one here. So what we need to do is have our sample volume behind this area of proximal flow convergence. So they talk about this being in the blue, which I quite like. So you can see in this trace here, the sonographers placed their sample volume in the flow convergence, which is given as a Vmax that's over 1.5. Yes, we can see a closing click, which is probably fine, but there's a lot of spectral broadening. And this is going to overestimate our VTI, which is going to underestimate the severity of aortic stenosis if we use this measurement. If we pull that sample volume back just behind the flow convergence zone and put it in the blue here, we're going to get a more laminar profile. We're not going to be in that spectral broadening flow convergence. And you can see how different the velocity is going to be and how different the VTI is going to be. And this is the one that we want to be using. And you can read more about it in this nice paper by Miller. They talk about it. There's a few more papers on it as well. Probably the hardest thing, though, I think, is once you've got over the other pitfalls with Doppler angle and stuff like that, is LVOT diameter. Really, really tricky, especially when they've got calcification. You can see here, this is a heavily calcified valve. Like where are you going to measure that? You can probably, if you ask 3 people to do it, they would all do a slightly different thing. They do say to measure it about three times and take the average. It's important that you zoom in a parasternal long axis. Obviously in mid-systole is where you're going to measure it inner edge to inner edge from where your right basal, the base of the right coronary cusp, to the base of the anterior mitral leaflet. That's where you want to be measuring. There is a little bit of controversy about this, and the BSE guidelines say that this is how you should always do it, and that you shouldn't measure more proximal in your LVOT. But the ASE guidelines are a little bit different and say that, so this is where you should be measuring, ideally at the annulus level. But and you can, if you've got flow convergence, so imagine if you've got lots of proximal flow convergence, then you can measure further back, like here, more proximal, to avoid that flow convergence, so that your sample volume, where you're going to do your VTI measurement, is going to be the same place where you do your LVOT diameter measurement. So this is what the ASE guidelines say you can do. You can read more about it here in this paper. But if you read the BSE guidelines, they say, regardless of whether you've got flow, turbulence, all of that, just measure at the annulus, don't move back into your LVOT. So it is a little bit controversial. I think most of the prognostic data, and certainly the ASE guidelines, do recommend that you can move back. Like this is actually taken from that paper. If you've got lots of flow turbulence there, depending on where you're going to put your sample volume. So it's not easy, which is why we all like a more simplified measurement, which ignores any error with your LVOT diameter, and this is your DSI. So as you can see, it's the same equation as your aortic valve conservation of mass equation, but you've lost your LVOT cross-sectional area, basically. So you don't have to measure LVOT diameter. And you have LVOT VTI as a numerator, aortic valve VTI as a denominator. And you can imagine, right, if your flow accelerates 4 times through a really small narrowing, then that's going to give you a ratio of less than 0.25. So that's where the 0.25 comes from, because that blood stream that's going through that really narrowed valve is accelerating 4 times. which is what the dimensionless ratio is measuring. There are a couple of pitfalls. There's not as much prognostic sort of outcome data using this as there is with aortic valve area. And it does ignore that natural variation in your LVOT area size, which changes, of course, will also have slightly different ones, so it ignores that as well. So some of the special circumstances just to finish off before we go on to some cases, is this idea that I talked about before of this discordant grading. So the two main ones that we have to contend with are this low flow, low gradient with reduced ejection fraction, and this is often called classical low flow, low gradient aortic stenosis, and that's because the EF is less than 50%, and you've got this low flow state. And the key value to remember for the low flow state is this stroke volume index of less than 35 mils per meter squared. So if you have someone with an EF of 40% and their stroke volume index is 30 mils per meter squared, and they've got, you know, a mean gradient of 30, a peak velocity of 3.3, but an aortic valve, so that's moderate, right? But an aortic valve area of 0.8 and a DSI of 0.21, then that's someone with discordant gradients, and they've got, you know, potentially classic low flow, low gradient, severe AS, but you couldn't necessarily call it that until you increased their flow across the valve and see whether, if you increase their flow, so increase their stroke volume index to more than this 35, and if their aortic valve area stays less than 1 and their gradient goes above 40 and their Vmax goes above 4, then that is true severe aortic stenosis, as opposed to pseudo-severe, where if I took that patient, give them dobutamine, for example, increase their flow up, and their aortic valve area increased up to 1.4, and their mean gradient dropped to like 38, and their Vmax dropped to 3.8 or something, then that would be pseudo-severe aortic stenosis. And that would be in a patient with flow reserve. So you're actually able to recruit them with dobutamine and increase their flows, which is probably a good thing that you're able to do that. You will have patients in that group where you give them dobutamine and they have no flow reserve. So you're not actually able to improve their stroke volume even with dobutamine. And that is a very poor prognostic marker in and of itself. The other group that you will see, and we see this a lot actually, I feel like we see this a lot in the ICU, is this paradoxical low flow, low gradient AS. What do I mean by that? I mean that's someone that has a low flow state but has a normal ejection fraction, and the 50% is the cutoff used. So someone that's, you know, going like, you know, by all intents and purposes, their ejection fraction looks normal, but their stroke volume index is less than 35 mils per second. And this is it here. So it tends to be older females with small cavity sizes, like sigmoid septum, and they have this small cavity. So despite their EF being okay, their stroke volume is down. And these patients can also present with, you know, those same hemodynamic values that I quoted. So having gradients less than 40, Vmax less than 4, but aortic valve areas and DSIs in the severe range. And these would be paradoxical low flow, low gradients, which are really quite tricky. And I forget the exact percentage, but a significant number of these patients, these paradoxical low flow, low gradients, will have cardiac amyloid, ATTR amyloid. So it's worth just, you know, these obviously need to be seen by cardiologists and sort of working through that as well. Any questions about discordant grading? Because it can be a little tricky. I must admit, I find these ones a little bit easier than, I find that the classics a little bit easier than the paradoxicals to sort of try and work through.
Sorry, Emma, I have a question.
Mm.
Can you use the DSI to help quantify in both high and low flow states?
Yes.
So if they've got, yeah.
Really good question. Yeah, sorry, I probably confused things a little bit with this slide, but essentially your DSI and your AVA but DSI is often easier because of the problems with LVOT diameter, will more or less correct for flow states. It's not perfect, but it will correct for that, whether you've got a high flow state or a low flow state. Your DSI is good for that, as well as your aortic valve area calculation as well. So because it's on the numerator and the denominator, it's sort of the flow problem itself sort of cancels itself out. So the DSI is useful in both.
I have a follow-up question. If they're in atrial fibrillation and got pulse pressure variation, is there a way of overcoming that? I know the cardiac anaesthetists like to do the continuous wave Doppler and then just trace out the denser profile as their LVOT, VTI, and what's your feelings about that?
Nah, I wouldn't do that. It's not recommended, and everyone that I've spoken to about doing that would caution against doing that. It's the problem that probably why you would do it is because when you're in the middle of a case or something, like, it's super easy to do, right? So why not? But you shouldn't be. That shouldn't be your default. It's not good practice. You can imagine why, right? So if I'm tracing that out, coming back to let me just show you this one. This is what they'd be tracing out. I mean, how inaccurate is that going to be, really? It'll give you a bit of an idea, but no, you shouldn't be doing that. You know, as your like gold standard, definitely not, and it is advised against. But I was going to talk about the other. So we've talked a little bit about this special circumstances, which is when you have discordant grading, high flow and sort of low flow. Another special, I'm going to come on to aortic atrial fibrillation because that is another special circumstance. So I might just put a pin in that and say what I would recommend doing in atrial fibrillation. We'll come back to it. This is a patient with low flow, so ejection fraction less than 50%. Lots of flow turbulence, really calcified aortic valve, severely restricted. LV looks down, probably a little bit thickened walls, probably concentric hypertrophy, but we'd need to do the measurements. Flow turbulence coming through the valve, terrible LV function. RV is probably not too happy as well. Aortic valve, flow turbulence, severely restricted. Vmax of about, have I put the numbers on, 3.3, so continuous wave in the apical 3 chamber, trying to line up as best as possible. This is actually a good example of what you just mentioned there. So you shouldn't be tracing that as your LVOT VTI. You could, I mean, look at how much. I mean, it's going to be really inaccurate. We also try to do this. I think this is my attempt actually at the right sternal edge. Look how terrible it is. So that was with it. What probe have I used here for this one? PDOF, yeah. So sometimes they're, I don't know, in the DDU Viva for an aortic stenosis Viva case, they might show you this picture, and you'd need to recognise that this was flow coming above the baseline. So it's probably coming from sternal edge, supraclavicular, or suprasternal, right? If they give you this kind of profile without the little thumbnail at the top, coming to above the baseline, just be aware of that because they will sort of show you that, I think. So this patient, a Vmax of 3.3, mean gradient of 25. So where does that put this patient in terms of severity? Thinking back to that table of aortic stenosis. Mild, moderate, or severe, based on gradients. .3 and 25.
3.3 would be moderate.
Yes. And then 25 to 40 was moderate as well, wasn't it? So this patient is in the moderate category. But what do we think of their aortic valve?
Well, on 2D assessment, it looks severe.
It does. It does look severe. So I'm thinking, could this be, and the EF is down, right? So I'm thinking I need to calculate. So my next step is I need to know what the SVI is. I need to know what the stroke volume index is to know whether I'm in a low flow state. Because could I be dealing with discordant grading? Right, so then the things that I'm going to look at there. Sorry, guys, it's not coming up. If you trust me, this one's meant to stroke volume, and the stroke volume index was something like 26 or something, so less than 35. So I'm dealing with reduced EF, reduced stroke volume, so low flow, low gradient potentially, in someone that has moderate values in terms of gradient and velocity. So the next thing that I want to do, I've worked out that we've got a low flow state and reduced EF, is I want to know what the aortic valve area is calculating as and what the DSI is. All right, so therefore I'm going to do LVOT VTI times my cross-sectional area, and taking into consideration that this maybe isn't perfect, but it is what it is. We have to do our best with that, divided by aortic valve VTI, and we get an aortic valve area of 0.67 centimeters squared, which is less than 1. So that puts our aortic valve area into severe. Yeah. And the DSI, which is the LVOT VTI over my aortic valve VTI, cancelling this out, comes out at 0.2, which is less than 0.25, which is severe, right? So now we have a patient where the 2D appearance looks like it's severe to me. The LV is down, the flow state is down. So we've got velocities and gradients that are coming up as moderate AS, but our DSI and our aortic valve area are coming as severe AS. Oh, there it is. The stroke volume index is less than 35. It's 23.4. So we are dealing with low flow, low gradient, potentially severe aortic stenosis. So low flow, low gradient AS. And this is discordant grading. So this makes it really tricky to then know, is this true severe or is this pseudo severe? So the first thing, however, that you need to do is check all your measurements, right? Because as we know, we can cause lots of inaccuracies here. Inaccuracies here are going to be, the error is going to be squared. So that's going to give us a lot of potential problems. And then we can get this completely wrong, can't we, if we haven't hunted for that highest velocity, which all of these have significant implications. So the first thing to do is assume that your measurements are wrong, check them all again. If it's still discordant, you're obviously going to be speaking to a cardiologist. And does this patient need to be referred for dobutamine stress echoes? Do you need to do an invasive cath potentially? And CT calcium scoring as well. So this is sort of a bit of a flow chart for how you would go through that. So classic low flow, low gradient AS, which is the patient that I've just shown you. So this would be a classic patient for this. So valve area less than 1. Mean gradient less than 40, EF less than 50%. Then you do this dobutamine stress echo and you want to see if they've got flow reserve or not, so they are able to increase their stroke volume. Those that are not able to increase their stroke volume, i.e. they haven't got flow reserve, that's actually a pretty poor prognosis, as I mentioned. Those that increase their gradients and still have a valve area less than 1, have got true severe AS, right? Probably need surgery. Those that you increase their flow and their gradients fall and their aortic valve area increases, they've got pseudo severe, and you probably just need to optimize their heart failure therapy. Obviously this will be MDT discussions and things, and then where it's sometimes indeterminate, then they can do these calcium scorings, but obviously this would all be led by cardiologists and things, but just so you have some awareness of the sort of guidelines for how you would manage that. So, as I said, these patients that have this low flow, low gradient, they have the poorest prognosis. So it does have a prognostic importance as well. So I suppose there are sort of 4 different categories, right? You can have normal flow, high gradients, which are nice, happy days. Everyone, that's easy. You can have patients that have low flow but still have high gradients because they've got such severe AS and they, it doesn't cause any trouble. They still don't have discordant grading. Don't see this that often. You can of course have normal flow, low gradient, where you haven't got so much severe AS, and the low flow, low gradient, which is the worst prognosis. And then not the final thing. This is another pitfall. So we've talked through discordant grading, and then the other thing to make sure you're not missing is this, dynamic versus fixed obstruction. So know your profiles. So AS, obviously you have this initially triangular going to parabolic. If you have dynamic outflow obstruction, for example, in a patient with Holcomb, or critically ill patients with whatever cause of dynamic LVOT obstruction, which we'll talk through in another session, they have this dagger-shaped sort of saber-tooth late peaking jet. So important to know the difference between what a dynamic obstruction looks like here and what a fixed obstruction looks like here. You definitely don't want to get those obvious. And then the final thing, which is I struggle with this a lot in clinical practice, is when the patient has aortic valve disease and atrial fibrillation. It's an absolute nightmare, really, really tricky. I'm just going to talk through what you can do. So you can essentially, you can average 5 to 10 beats. I think most people would choose 5 because 10 is a bit painful. So you could trace this, and take the average peak velocity and mean gradient, right? And then you can use your averages to work out aortic valve area and things like that as well, and DSI. But what's been looked into more recently is whether you can actually just match a single cycle length from both your continuous wave through your aortic valve and your LVOT VTI, whether you can match those 2 RR intervals. And ideally we should use the longer RR cycle, because that correlates pretty nicely, as shown in this really nice paper actually, that if we use the standard method, which is averaging 5 to 10 beats, which is here, and use these values to calculate our aortic valve area in centimeters squared. If we do the same thing but just use 1 cycle, so matching up the RR intervals, which I'll show you on the next slide, choosing the longer one, the correlation is 0.96. It actually correlates reasonably well. And they've said that aortic valve area can be measured with a single cycle length and a long cycle is preferred. So I must admit, this is what I've started doing, and chatting to, cardiologists and things here in our lab. A lot of us do this, just matching that RR cycle, the longest one. And this is from the BSE guidelines, who also recommend doing this as well. So this is how it would look. You would match your RR interval for this one is the same as for your continuous wave, and you try and match that as best you can. So having a similar RR interval between your LVOT VTI trace and using this one and this one with matched RR intervals. And the reason you do that is obviously the longer your RR interval, the higher the blood volume is going to be when it empties. And so trying to match them as much as possible. And then you can use the values of these two to work out DSI, aortic valve area, things like that. And it seems to correlate pretty well to doing the 5. And I like it because it's just much more pragmatic, right? You can just match the R intervals and it works pretty nicely. So that's what I tend to do in AF. Any questions about that? All right, should we finish off with a couple of cases? I think I've just shown you this one, but we'll go over it again just to get you guys talking about it. So oh no, I haven't. This is a new one. 43. Actually, do you want to read it out? Because in your Viva session, you will they'll get you to read out the stem as well. So does anyone want to have a bit of a practice at doing this? Maybe those of you that
I can have a go if you like.
Yeah, go for it, Rob. Nice one.
So 43-year-old with urosepsis on 20 mils an hour of noradrenaline. There's a ejection systolic murmur heard on the ward round. Transthoracic echo, valve pathology, query AS, and biventricular function, query whether there's a cardiac component to the shock state. Previously told systolic murmur, never followed up. So this is a parasternal long axis view, transthoracic echo. So I guess my immediate findings, I can see that the left ventricular function on this view looks sort of normal. There's increased LV wall thickness. The right ventricular outflow tract, the ascending aorta or aortic root and left atrium approximately the same size, although the aortic root does look like it might be dilated, and looks like the STJ is effaced in this view. And then concentrating on the aortic valve, it appears heavily calcified and there's restricted motion during systole. So I'd want to interrogate that with zoomed in view and from other axes. So this is a zoomed in view looking at both the aortic valve and mitral valve. Again, the aortic valve is heavily calcified and there appears to be restricted opening. Mitral valve leaflets look like normal morphology. They're opening nicely. I can't see any evidence in this view of any LVOT obstruction or SAM. So this is colour flow Doppler across that aortic valve in the zoomed in view. I can see that there's turbulent flow during both systole and diastole. So there's evidence of what appears to be eccentric aortic regurgitation. And then again, turbulence during systole, which would correspond with the 2D assessment of restricted opening concerning for aortic stenosis. This is a parasternal short axis zoomed in view of the aortic valve. Again, in the aortic valve, leaflets appear heavily calcified. I can't remember the age of the patient, but given
43.
43. So my concern here is that this patient might have congenital bicuspid aortic valve. It appears in this view like it doesn't appear like there's 3 leaflets. And again, like I said, the aortic root was like the STJ was effaced, so with possible aortopathy associated with that. So this is again short axis through the aortic valve, but with colour flow Doppler. It's a bit difficult to assess with the frame rate, but it appears like there is. I want to slow it down, but it looks like there might be some aortic regurgitation during diastole.
I might just Sorry, I might just skip that one, Rob.
Yeah, that's fine. So this is zoomed in apical 5-chamber view looking at the aortic valve and aortic root. You can see that there's turbulent flow during systole, during the aortic valve, and then again the aortic regurgitation. It'd be useful to quantify some of these findings with spectral Doppler.
I see you.
So I'm not sure if you can hear that, but I'm going to ignore it. This is a spectral Doppler trace through that aortic valve apical 5-chamber view. So the peak velocity is greater than 4 meters per second. Mean gradient is greater than 40. It's calculated the velocity ratio for us, which is 0.25, and it's also calculated the aortic valve area index to body surface area, and that's all within the severe category. I guess the caveat to this is that the patient is in a high flow state, but as said, the DSI is less than 0.25, so it would be severe. This is a continuous wave Doppler through the aortic regurgitation jet, and so we could use this trace to measure the pressure half time and grade the severity of the regurgitation. This is the LVOT VTI trace. I'd be cautious of where the sample gate is. It appears to be within turbulent flow section, so it could be overestimating the LVOT VTI. It's giving us a stroke volume of 90 mils. Yeah, but like I said, it could be an overestimation given where the sample gate is.
Nice,
So
Rob. So, yep, so when you sort of correct for that LVOT VTI, this actually goes down to 0.2 or so rather than 0.25. And aortic valve area goes down to about 0.98 when we do that. So putting it together then, how would you summarize this in your conclusion?
So putting it all together, so I guess this gentleman who's got septic shock in the setting of E. coli urosepsis, and so likely high flow state from that, the assessment of the ventricle looked like it was normal. But despite all of that, it has got multiple parameters suggesting severe aortic stenosis.
Yeah, very nice, Rob. Obviously, being a bit mindful to definitely hang your hat on that when they're critically unwell. But as you say, parameters in keeping with severe AS, and probably you need to have a few more measurements. But I know this outcome of this patient with moderate AR as well. So severe AS, moderate AR, and they actually went on to have valve surgery in the end. But after he was over his critical illness and things, so it's really, really nice. And guys, I've got a toll list that I need to get to, so we'll just be really quick running through. In fact, can I, rather than show you this one, because this, I must admit, this is the case that I've already kind of shown with the discordant gradient. We've kind of gone through it. So if you don't mind, I'm just going to skip through that. But I might just, if I can, show you this really cool case that the highest gradient came from the subcostal window, just to prove that sometimes it can. I'm just going to anonymize it on single, which is, and then share the screen on here, hopefully. Let me figure out how to do it. Teams. Window, single. Can you see it? Can you all see single? No. Share. Stop share. Oh, it's working for me. I did teach this morning with that. Hopefully we can get it to work. How about if I drag it over? Oh, yeah, can you see that?
Yep.
Yeah, nice one. All right, so I just want to, this is a, I'll just go through the images. They're actually quite terrible. But I just want to show you something towards the end. Really awful images, right? I mean, this is often what we see. You just can't see anything here, right? This is sometimes what you get. But I just want to go through. So we're starting to get some Doppler through the aortic valve, 3.5, around 3.5 to 3.8. Not very good VTI trace, as you can see. I'm only sharing half of the study here, actually, because it's on the other screen as well. But can I just show you this? So here we're in the subcostal window. We have, I need to share this screen. Let me just try and pull it across. I just want to show you this color Doppler before I stop sharing. Share. Cool, guys, can you see that? So subcostal 5 chamber. Turbulent flow through your aorta, some aortic regurg as well. And you'll see that the Doppler tracing in the subcostal view, continuous wave Doppler, gives us a Vmax of 4.1. So the highest gradient for this patient was actually found in the subcostal region, which is pretty cool. It's not very often you see that. So I think we'll leave it there, guys. Sorry, I have to rush and I've gone over again by about 10 minutes and I'm sorry for being late. But yeah, let me know if you want any of the resources that I referred to. But otherwise, I'll see you next time. Thanks for joining.
Thanks, Emma. Thank you.
Bye.
Thanks so much, Emma.
Bye.
Bye.